Started. My name is LaShonda Williamson Jennings, and I'm the co-director of the Southwest Prevention Technology Transfer Center. Today, we'll have Josh Esrick and Emily Patton from Carnevale and Associates present to you understanding and addressing methamphetamine use in the Great Lakes and the Southwest. Our next slide is the disclaimer slide, and it simply shares information about our grants. It also tells you all that the opinions and the content expressed in this product do not necessarily reflect the views and opinions or policies of SAMHSA. I'm excited that I get an opportunity today to introduce to you all Josh Esrick. Josh is the Senior Policy Analyst with Carnevale Associates. Mr. Esrick has extensive experience researching, writing, evaluating, and presenting on substance use prevention and other behavioral health topics. He has developed numerous substance abuse and mental health services administration, prevention technology, transfer center for the application of prevention technologies, products, and trainings. Among other projects for SAMHSA, he has helped write annual data collection, analysis, and reporting reports. He's conducted evaluations of the Strategic Prevention Framework, state incentive grants, some of us call it the SPIF SIG, and wrote the monthly financing focus for the Center for Financing Reform and Innovation. Mr. Esrick has published in the International Journal of Drug Policy on considerations surrounding marijuana legalization and in drugs, education, prevention, and policy on the modern usage of fear-based prevention messaging. And next, Emily Patton is the research associate with Carnevale Associates. She offers over 9 years of expertise in data analysis, program management, and evaluation. Under the District of Columbia Department of Behavioral Health, she provides data analysis, programmatic support, and training and technical assistance to multiple contracts that serve youth and families in the district. She also serves as a research associate with the PTTC Central East region. In this role, she provides expertise in substance use prevention, mental health, and program management. Prior to joining Carnevale and Associates, she worked for CSR Inc., serving as lead analyst for the Edward Byrne Memorial Justice Assistance Grants Program, which is the largest source of federal justice funding in the country under the direction of the Bureau of Justice Assistance. You all, I'm going to turn the time over to Josh Esrick and Emily Patton. And again, thank you all for joining us today.
All right. Thanks, LaShonda. Hi, everyone. I want to thank you all for joining us today. I hope you're all doing well. Before we get started, just a couple quick housekeeping notes. First of all, we've got a lot of content we're going to try to get through today. So if you have any questions at any time, please feel free to ask them, and either Emily or myself will do our best to answer them as they come up. We're also going to try to have some time for questions and answers at the end of the webinar as well, if you'd like to wait until then to ask your questions. In addition to that, at a few points throughout today's webinar, we're going to ask you all some questions to get your thoughts and opinions and feedback, and feel free to use the chat to respond to those questions. And also feel free to use the chat to just respond or react to any of the things that we're talking about, or to answer your fellow participants' questions if you have some thoughts to share on those. If the chat becomes a bit of a free-flowing conversation that accompanies the content today, that would be great. So our learning objectives for today are, first of all, we're going to examine the trends in and impacts of methamphetamine use. So we're going to talk about use and about consequences. And we do have quite a bit of data to share with you today. We're then going to overview the current evidence base for methamphetamine use and overdose prevention strategies, talking about what we know and what we don't know. And then lastly, we're going to spend a bit of time exploring some recommendations for improving methamphetamine prevention going into the future. So moving right into our first topic, which are the current trends. And actually, I see a note before actually we even talk about the current trends. I want to note that a lot of what we're going to talk about today can also be found in a brief that we have created for the South, Southwest, and Great Lakes PTCs. I believe a link to it has been placed in the chat a little bit earlier. And that brief goes into a lot of the same topics as today. Some of them we're talking about in a bit more depth in this presentation because we have 90 minutes with you all, but that is a nice handout / takeaway that you can share with others easily. So diving right into things, before we can really talk about what we know about methamphetamine use trends, we need to talk a little bit about the impact of COVID-19 on substance use, because COVID-19 has impacted pretty much all aspects of life in the United States and around the world, and that includes impacting our ability to do data collection in substance use, and also impacting substance use trends, we think. There isn't a lot of hard data yet on what's occurred during the pandemic. Available data, which we will talk about, suggests substance use overall did dramatically increase last year, but with the data collection problems that have been going on, we might never have a totally clear picture of what happened. So, just as a note here, most of what we're talking about today is really just going through the end of 2019. So it's telling us where things were before the pandemic began. Now, a note on data collection problems, as an additional note rather, as some of you might have seen, SAMHSA just yesterday released the 2020 NSDA data, National Survey on Drug Use and Health, and which is one of the premier sources of substance use data in the United States. And they released that data with a very large warning to not make any comparisons between their 2020 data and prior years because of methodological challenges around COVID-19. But if you do look in that data, you'll see that if it does get confirmed through other sources, it actually shows a very dramatic increase in methamphetamine use in 2020, about a 47% increase in use. So don't take that as gospel, again, because the NSDA data is not, we don't know for sure how accurate it is yet, but it is just another indicator that substance use probably increased quite a bit during the last year and a half. Some other data that we have on what's happened in the past year and a half is a number of different surveys, many of which have been conducted by the CDC, but also various independent researchers as well, have found that a lot of risk factors for substance use around things like stress, anxiety, depression, trauma, social isolation, things of that nature have all significantly increased. One really noteworthy data point from early on in the pandemic, when the CDC did a survey about substance use of all adults 18 and older, and they had a sample size around, I think it was around 30,000 people, although don't quote me on that one. But it was a very large sample, and they found that 13% of adults stated that they had either started or increased their substance use to cope with the pandemic and sort of its impacts. Another data point we have that suggests that substance use has gone up a lot in the last year and a half relates to the last bullet point here, which is that provisional fatal overdose data shows an increase of about 30% in the death rate in 2020. Now, obviously, overdoses have been going up most years for the past 20 years as the opioid epidemic has worsened, but there's never been an increase like that. And as a point of comparison, in 2019, there was a 7% increase in fatal overdoses. So even if we would expect the number to go up a bit in 2020 anyway, even if it hadn't been a pandemic, it seems to have gone up a lot more. And then lastly, I want to note this, the third bullet point there, which is data that comes from the DEA and their annual drug threat assessment, which is that they note that the methamphetamine supply chain has been pretty much entirely unaffected by the pandemic. I think we've all seen news stories about various legal products, things like consumer electronics, cars, and so forth, that are all getting harder and harder to find due to the pandemic. Methamphetamine is not among them. The DEA has said that some suppliers and producers might be artificially withholding supplies of methamphetamines to try to increase the price. So if you have seen or heard about methamphetamine getting harder to find in your community, it's likely because of that kind of voluntary action and not because the pandemic has actually changed anything. There's a lot more that we could say about the impact of COVID-19, but we do want to focus more specifically in today's presentation on methamphetamine use. But before we dive, and its consequences, But before we dive into that data, I do have a question for you all. So please feel free to share your thoughts on this in the chat, which is what substance use trends have you seen in your communities since the COVID-19 pandemic began? And this could be methamphetamine specific or just in general. What have you seen? And I will pause for just a few moments to give you all a chance to think about that. And I'd love to see your thoughts in the chat. All right, so I see vaping and marijuana, alcohol increases, especially with delivery services, increased preference of fentanyl, heroin and fentanyl increasing use, a general increase in use and misuse over the course of the pandemic, increases in overdose and methamphetamine, fentanyl, opiates and meth, methamphetamines, alcohol, fentanyl and stimulants, use and marijuana vaping products. Wow, yeah, a lot of people sharing in the chat. Great, really appreciate you all doing this. Counterfeit drugs on the rise, increase in Delta 8 and 9, increase in K2, alcohol and stimulants, alcohol and vaping among young people. Yeah, just the list goes on. And if you haven't shared your thoughts yet, please add them to the chat. So yeah, this isn't surprising as just sort of we shared based off the data we have so far. And the thing is, because of the data collection challenges, it gets hard though to know what are the exact scopes and magnitudes of these problems. And so it just sort of illustrates the need that if you haven't yet, to really consider how are you going to be doing data collection as the sort of hopefully tail end of the pandemic continues, because we really do need to get so the hard data on all of these anecdotal increases. And if you already have hard data and this isn't just anecdotal, that's great as well. So thank you all for sharing that. We're now going to dive into a bunch of methamphetamine specific data, beginning with use data. And so to kick that off, I'm going to turn things over right now to my colleague, Emily, who will lead us through that. And I'll be back in a little bit to talk about the overdose data. So thanks again for joining us. And Emily, why don't you take things away?
Great. Thank you so much, Josh. Hi, everyone. My name is Emily Patton, and I'm really excited to be here with all of you today. The next section that I'm going to be talking about is going to cover looking at methamphetamine use and the trends we've been seeing. Based on the chat, some of this may not be surprising to you as we go through the data, but please feel free to put feedback and questions in the chat so that we can get those addressed to you. We all know that methamphetamine is a highly addictive central nervous system stimulant. And in recent years, methamphetamine availability and methamphetamine-related harms have been increasing here in the United States. In fact, our data shows that methamphetamine, as well as stimulants in general, may be sort of that next major epidemic facing the country. In some regions, we know that methamphetamine has been endemic since previous waves of use. But this newest wave that we're seeing is different in important ways, which we're going to talk about today on these next couple slides. Just some general trends that we've been seeing, from 2016 to 2019, we've seen past month methamphetamine use increase by 76% nationally. Data compiled from NISDA also shows that 36 states have experienced an increase in methamphetamine use between 2017 and 2019. And the most recent year of data showing us that 27 states had higher rates of methamphetamine use compared to the national average, which isn't uncommon and to be expected. We also know that between 2015 and 2018, there was about an average of 1.6 million adults who reported annually that they used methamphetamine. And nearly a quarter of those individuals reported that they were actually injecting methamphetamine. Additionally, data suggests that around 50% of methamphetamine users meet the criteria for a methamphetamine use disorder diagnosis. However, unfortunately, we know that most are not receiving treatment that seems to be needed. In fact, fewer than a third of adults with past year methamphetamine use disorder received substance use treatment in the past year. We also see that methamphetamine use significantly overlaps with mental health, and that folks who use methamphetamine may have a higher likelihood of having a mental health disorder. There's some overlap there. So of individuals who use methamphetamine from 2015 to 2018, an estimated almost 58% reported experiencing any sort of mental illness, and 25% reported a serious mental illness during the past year. We also know that polysubstance use is not uncommon among individuals who are also using methamphetamine. So among adults using methamphetamine within the past year, there's estimated prevalence rates of past year use or misuse of other substances, such as 69% also reported using cannabis, 40% reported prescription opioid misuse. We have 30% also reported using cocaine, 29% for prescription sedatives or tranquilizer misuse. 22% of methamphetamine users also reported prescription stimulant misuse, and then 17% also reported heroin use. Additionally, past month binge drinking was reported by an estimated 46%, and nicotine dependence by about 44% of methamphetamine users. Okay. So getting really further into the data, and about who is using methamphetamine, we see several trends that are sticking out. We know that men are almost twice as likely as women to use methamphetamines, although this gap is a bit narrower when it comes to youth and young adults. We see that Native Americans, Alaska Natives, and as well as Native Hawaiians and Pacific Islanders tend to have the highest rates of methamphetamine use in the country currently. We're going to dive into that a little bit more on the next slide when we talk a little bit more about what we're seeing in terms of race and ethnicity in terms of use. We also know that methamphetamine use is strongly associated with lower educational attainment, such as having an education less than a college degree. The data also shows us that for folks with an annual household income of less than $50,000, they're more likely to be using methamphetamine. Folks who have Medicaid only or no insurance, as well as those individuals living in small metro as well as non-metro counties, so more rural areas. We also see methamphetamine use among unemployed adults doubling or almost doubling between 2018 and 2019. So all of these findings really kind of provide us with that needed insight into the populations that are being most affected by this type of substance use, and can really kind of help us to better prioritize prevention and response efforts, some of which I'll cover a little bit later. For example, the identification of higher rates of methamphetamine use in rural areas are important, given we know that there are some difficulties in delivering services to those populations who are being disproportionately affected by methamphetamine use. So this chart shows us what populations based on race are reporting methamphetamine use. As discussed on the previous slide, we see that use is highest amongst our Indigenous communities. However, we are seeing decreases in recent years among those populations, which is promising. For example, for Native Hawaiian and Pacific Islanders, their data shows a marked increase in methamphetamine use from 2016 to 2018. However, 2019 data is showing us a significant reduction in their use. This is similar to what we see amongst Native American and Alaska Native populations, which experienced an all-time high based on the data that we're seeing for these years in 2017, but then that was followed by significant reductions in use from 2018 onwards. So future years data, once we can get it, and I know Josh has mentioned there's been some data issues, but hopefully as we get some more years rolling out, we're really going to be able to track a lot better where those trends are heading. We have seen year after year increases in methamphetamine use among Caucasians, as well as generally steady increases in use among those who identify as two or more races. And then we also see that methamphetamine use rates continue to generally remain low in Black and African American as well as Asian communities. And then now we'll talk a little bit about past year meth use based on age. In a potentially important change from prior waves. The increase in methamphetamine use really appears to be driven by new initiations among people ages 26 and older. This trend differs from previous waves of meth use when much of the increase was driven by younger individuals, specifically those who were between the ages of 18 and 25. Further illustrating, this point, in 2019, use rates were almost identical between the 18 to 25 age group and the 26 and older age group, whereas in 2005, use among the 18 to 25 age group was almost 5 times higher than use among those aged 26 and older. So in this table, we can really see year after year increases in methamphetamine use among individuals aged 26 to 29, as well as 35 to 39. And then we're seeing those aged 30 to 34 and 40 to 44 also seeing significant increases in use almost every year. So we're seeing that sort of bell curve shift a little bit in terms of age. There are a couple of reasons why this may be happening. And hopefully additional data and supplemental research will help explain some of this. But it could be that methamphetamine users are simply aging into a different cohort. But the data is also showing us that new initiations are occurring among older folks here in the States. So we really kind of need that research to better understand whether risk patterns among methamphetamine users has changed, as well as how different age groups may be more vulnerable to using this substance. And some of this may also continue to go back to COVID-19 as well. So that's sort of our national overview on what we're kind of seeing at the national level in terms of methamphetamine. So now we're going to turn specifically to the Great Lakes and the South-Southwest regions. Since 2017, methamphetamine use has increased nationally, which we talked about, as well as in 7 of the 11 states in the Great Lakes and Southwest regions. Although use remains relatively low compared, especially with opioid use, for example, and the year-over-year increases may not always be statistically significant. Prevention professionals really should be prepared to address these trends before they potentially worsen in terms of methamphetamine. As I've said, we've been seeing increases year after year, generally in a lot of states in these regions. We also know that methamphetamine use is above the national average in 8 of the 11 states in the regions that we're looking at here today. So following that national trend, methamphetamine use in both regions generally is more concentrated among those age 18 to 25. However, methamphetamine use in those age 26 and above really appears to be increasing among almost every state in both of those regions, which is mirroring what we're seeing nationally. And the trend showing that this group may actually surpass those age 18 to 25 as newer data becomes available. So here we'll talk a little bit about methamphetamine use in the Great Lakes. And so among the states represented here in this region, Indiana, Minnesota, and Wisconsin have past year meth use rates consistently higher than the national average, with Indiana experiencing the highest rates of methamphetamine use regionally year after year. Additional data for those aged 18 plus, so not shown on this chart, but in the actual data sets, show that several states experiencing year after year increases in methamphetamine use, with much of the growth stemming from those, again, in those age 26 and up. And those states are Illinois, Indiana, Ohio, and Wisconsin, which is mirroring that national trend. So the only states experiencing decreases in methamphetamine use are Michigan, which has shown reductions year after year, and Minnesota, which saw quite a large drop in use from 2017 to 2019. So a question I have for you all that you can answer in the chat is, in what parts of the communities that you serve have you been seeing methamphetamine use, and has this changed from prior years? And feel free to answer that as I go on to the next slide, which is going to look at this data in the South-Southwest region, and then I'll come back to your responses after that slide. So turning to the South-Southwest, as we can see from this chart, every state but Texas now has higher use rates than the national average in this region, with year after year increases in use being seen in Oklahoma, as well as in Louisiana. A little bit promisingly, New Mexico and Texas have been seeing steady declines in methamphetamine use, and hopefully we will continue to see that in future years. Additional data shows us that New Mexico, Oklahoma, and Arkansas have the highest past year meth use amongst those aged 18 to 25. Generally, most states in the region have been seeing a steady decline in use in that specific age group, that 18 to 25. But again, data for those age 26 and above, so the older populations that we're starting to see in Arkansas, Oklahoma, and Louisiana show increases in use, with rates in Arkansas and Oklahoma actually doubling in that age group between 2016 and 2019. So just to go back to the question, what parts of the communities that you serve have you been seeing methamphetamine use? Has it changed from prior years? Seeing a lot of folks saying rural areas, which really kind of goes on trend with what we've been seeing with the data. Not much change. Okay. We're seeing 20 to 35, but some older, which is to be expected based on the data. So definitely rural. And just to answer one of the questions, yes, this is NISTA data. Native American communities have been seeing an increase anecdotally, but that does sort of track with what we've been seeing nationally as well. Okay, great. And we're seeing some folks who are unhoused, adults who are unhoused, polysubstance users, and then even some young people, those aged 12 to 17, which we do see in the data, those in that younger age group, that there is some use, but it just is nowhere near the levels that we're seeing now in 26 and above, and then really where most of the methamphetamine use has been concentrated in those aged 18 to 25. So really, really appreciate all the feedback, really great information. So at this point, I'm going to hand the presentation back over to Josh, who's going to talk a little bit more about the impact of methamphetamine use. So Josh?
Thanks, Emily. Hi again, everyone. Thanks to Emily for sharing all that use data with us. So as Emily said, I'm going to talk a little bit now about the impact of methamphetamine use, and it really gets to the heart of why we should be taking this so seriously already. As Emily shared, a lot of the the use data is increasing, but of course, if you compare it to opioid use data, it is still quite a bit lower. However, methamphetamine use is already having an outsized impact on people. So first of all, methamphetamine use, as with pretty much all substance use, can cause a variety of different physical and mental health issues that can dramatically decrease quality of life. Methamphetamine use, in particular, compared to other substances, has an awful lot of impacts, ranging from heart problems to dental problems to insomnia to mental health disturbances to violent behavior to psychosis, and many other potential impacts as well. However, a lot of those impacts can be hard to track data on. Trying to find out, for instance, the number of people that are experiencing potentially dangerously high blood pressure because of methamphetamine use, that's a hard data set to collect, and isn't really collected at the national level. It's something that you would have to sort of be looking out on your own and finding local sources of data that could help you learn more about that impact in your community. But one consequence of data, which is easy to track, is fatal overdoses, because of the National Vital Statistics System run by the CDC, which gets data from all of the states, who get data from all of their coroners or medical examiners, whatever the system that state might use is. Now, it's important not to rely too much on overdoses as a measure of the scope of a trend, because there's so many different variables that go into whether or not an overdose will occur at all, as well as whether that overdose will become fatal. But they do help us, understand the severity of a trend quite a bit. Now, one last point I want to make about overdoses is actually about terminology. So I am calling them overdoses, and I think we're all pretty familiar with what the concept of overdoses are, from all of our work with the opioid epidemic. There are some organizations that, when it comes to stimulants, they don't use the term overdose. They use the term overamping because of the thought that it's harder to pinpoint the relationship between dose size and consequences with stimulants than it is with opioids. However, both overdoses and overamping refer to substance toxicity leading to various serious health conditions that can often result in death. So if you do see the term overamping, that's what it means. I'm using the term overdoses, which is what certainly all the federal agencies that I've seen use. So just a note on that. So digging into the data then, this next slide shows the fatal methamphetamine involved overdose rate for the nation, as well as the Great Lakes states collectively and the Southwest states collectively. Now this data is showing not the raw number of overdoses, but rather the fatal rate per 100,000 people, which is a way to calculate overdoses or any data set for different population sizes, so you can make comparisons across them. Because obviously if we just showed the raw numbers, the nationwide number would be much higher than either region because there's so many more people in the country. However, you can see that when we do normalize for population and show this fatal overdose rate, per 100,000 people, we see pretty dramatic increases in both regions as well as the nation, although the nationwide rate is a little bit higher there. If you do want the raw numbers, in 2019, there were 16,167 fatal methamphetamine involved overdoses nationwide. There were 2,252 in the Great Lakes states, and there were 1,999 in the Southwest states. Now, this data is not showing the deaths that were just caused by methamphetamines and nothing else. It's showing the overdoses that involved methamphetamine use. So if another substance was involved as well, it would still be counted here. And then, like, for instance, if fentanyl was involved and you looked at fentanyl involved overdoses, the ones that involved methamphetamine as well would be in that count. The categories aren't exclusive. And because of that, you do find some people saying, maybe less now, but certainly something I've heard in the past is, well, there's not a stimulant problem, there's just an opioid problem, and the stimulants stem from that. However, as the next slide shows, this isn't the case. So this slide shows nationwide the number of fatal methamphetamine-involved overdoses, both the ones where no other substances were present, as well as the ones where opioids or cocaine were present. And what you can see is they're both going up. So yes, there obviously are connections between methamphetamine use or stimulant use in general, as well as opioid use, and sort of the consequences of which. You can see that the number of deaths that did involve opioids or cocaine as well increased from 2,466 in 2015 to 9,013 in 2019. However, the number of overdoses where there were no other substances involved, it was just methamphetamines, still increased by 120%, from 3,250 to 7,154. And it's also worth noting that those overdoses that did involve opioids or cocaine, there's no way of knowing if that overdose or the death still would have occurred if it was just the opioids, if methamphetamine hadn't been involved, or if it's because of the combination that it led to that. So this is very much its own problem, as well as a problem that overlaps with the opioid epidemic. And overall, over the last 5 years, 48.3% of methamphetamine overdoses have been just occurred by themselves with nothing else present. And if you look at the state data, which I don't have up on this slide, you'll see that over in the Southwest states, in 4 out of 5 of them, over 50% of methamphetamine overdoses did not involve opioids or cocaine. The highest number was Oklahoma, where it was 75% of methamphetamine overdoses occurred by themselves. In the Great Lakes states, the numbers are quite a bit lower. In most states, it's about 30%, so there's much greater overlap with the opioid epidemic there. But you do have, for instance, Minnesota, where 56% of methamphetamine overdoses didn't involve opioids. So that's just a little bit of the deep dive there. Now, this next slide shows fatal overdose rates for different age ranges, and also goes all the way back to 1999. And again, shows the fatal overdose rate per 100,000 people. And there's 2 important things to note here. First of all, we see that middle-aged adults are at the highest risk of use. The 35 to 44-year-olds have the highest rate overall, followed by 45 to 54-year-olds. And then you get 25 to 34-year-olds, and the other age ranges from there. So we can see that middle-aged adults are at the highest risk for a fatal overdose. The other thing to note about this slide is that you can see what the fatal overdose rate back in like 2004, 2005, 2006 was, which was so the last time that nationwide there was a major concern about methamphetamine use. Obviously, in some states, the epidemic never went away, but nationwide there did start being a lot less attention after around 2008. And you can see there was a little bit of a bump there in the overdose rate compared to like 1999 or 2000, but it is nothing compared to what it is now. And as the data on the previous slide shows, some of that likely is because of the opioid epidemic, which wasn't as bad back in 2005 because fentanyl wasn't really an issue yet. But even if you said that, every overdose that involved opioids doesn't count when we're talking about meth, and you cut all the 2019 numbers in half, they'd still be about 5 times higher than the overdose rate back in 2005 was. So something very different is going on now than in previous, in the past wave of use, and the consequences of use are much more severe than in the past. And we're actually going to dive a little bit more into that in a few slides. But before that, there's just a couple other points I want to make about overdoses in general. So this slide sort of reiterates the point about different risk by age, and you can sort of see those raw numbers and how much higher they are among middle-aged adults. But it is worth pointing out, when you look at a percentage increase, it's actually older adults and senior citizens that have seen by far the highest increase in fatal methamphetamine-involved overdoses. You can see that 65 to 74-year-old age range, they went from just 9 overdoses in 2005, and I picked that year as sort of the heart of the past wave of use, to 584 in 2019. So, that number is still quite a bit smaller than you see with the younger age ranges, but that is a enormous increase in the number of overdoses. And so a question I have for you all is, based off this kind of data showing that, the largest increases in at least overdose consequences are among older adults, as well as, Emily's data showing that we're starting to see many more of the methamphetamine initiations are among adults over 26 rather than 18 to 25-year-olds, which is different from what was going on 15 years ago. What are your thoughts on how we can work to reduce use and overdoses, specifically among older adults? And so I'm going to pause for a moment to give you all a chance to respond there. So I see Melissa shared, find out why they're using in the first place. Tina, help them understand risks and dangers. Mindy, reduce stigma about seeking help. Yeah, I think these are all definitely great thoughts on this. Address mental health issues. A whole lot of answers coming in now. Finding places to get help. At risk of harm, resource options and education, reduce stigma and increase treatment access. Increased psych access for treating ADHD, decreasing loneliness and social isolation among older adults, understand their use and educate them, have more available mental health supports. Yeah, I think these are all great thoughts, and I think definitely these could all be helpful. Obviously, in your own community, yeah, that first step is finding out why this is occurring, and then go from there. And what exactly is the best fit for your community needs are going to depend on what your needs assessments find. But this is something I really, if you get one takeaway from this, is from this whole webinar, I really do want to put on your radar that this isn't just a youth issue, and in prevention, I know a lot of times we do focus more on youth, and if you look at a lot of substances, the largest rates of use are among youth or among young adults. And certainly that is a concern among methamphetamine use still as well, but the current trends are really initiations occurring among older adults. And so we really need to think through how we can respond to that. This next slide then, moving on, and thank you all again for your responses, just shows the fatal overdose rate by gender, and just male and female, because that's the only responses that the CDC has. And you can see that one does mirror Emily's data about use, where overdoses are higher among men than among women. However, the relative increase among men and women has been pretty similar. over the past 5 years, there was a 171% increase in fatal overdoses among women and a 188% increase among men. So even if the raw numbers are the higher among men, we need to be concerned about both. And then lastly, talking about data, seeing the fatal overdose rate, again, normalized to population differences by race. You can see that the highest rate of overdoses are among American Indian and Alaskan Native populations, which is not surprising considering their higher rates of use, followed by white populations. And then we see that, even though in just talking about use, we haven't seen much of an increase among African American or Asian populations. They also are seeing increases in fatal overdoses, not to the same extent as the other populations, but they are going up. So this last slide then about overdoses tries to get back to this question of why have methamphetamine overdoses skyrocketed? And it is something we do need to answer because obviously, we want to prevent, people from experiencing harms, and that's one of the main goals of prevention. But we really want, one of the biggest harms, of course, is death, and so we are concerned about overdoses and why they're occurring and trying to stop them from occurring. And when you look at that overdose data and see just how much it has increased compared to the use data, it does open up the question, well, why has it gone up so much? And so there's sort of, as far as I can tell, pretty much 4 theories as to why this might be the case. And each of them might be contributing to the issue, or maybe none of them are, although I find that surprising. So to go through them, the first theory is that use rates today may be significantly higher than previous waves of use. And so you might have noticed that I did have that overdose slide that went back to 1999, but we didn't provide any methamphetamine use data going back to 1999. And the reason for that is because the data we were using, the NISDA data, they changed their methodology around methamphetamine questions in 2015, and basically said, don't compare the previous data to the current data because we're asking a different question. So we can't make direct comparisons, but it is possible that, trying to eyeball it, which I don't recommend doing, that's why this is just a theory, but it is possible that methamphetamine use rates are in fact quite a bit higher now than they were in 2005, 2006, 2007. Another theory is that methamphetamine may be much stronger now than it was in the past. And in fact, the DEA has reported, for instance, that the average purity of methamphetamine that they seized increased from 54% pure in 2008 to 97% pure in 2017. And this likely relates to sort of the change in supply of methamphetamines, where in the past wave of use, the primary source was domestic labs, whereas today there are far fewer domestic labs and the primary source are industrial scale production by transnational criminal organizations that produce it overseas. There is also the issue that methamphetamine is more likely to be taken in combination with other overdose-inducing substances, and I showed that data before. So that could help explain half of the overdoses, but doesn't explain what's going on with the other half. And then lastly, there is the potential that overdoses may have been misclassified in the past, and that overdoses were in fact higher than we think they were, because in a lot of states, medical examiners as well as coroners have significant discretion in how they classify deaths. And as we'll talk about in a bit, when it comes to barriers, methamphetamine overdoses are in fact very complex medical events. So it is possible that in the past, deaths just they just weren't listed as methamphetamine being the underlying cause of death. Maybe it was just listed as a multiple cause of death, or maybe it wasn't listed at all. There's the research showing that in some areas, medical examiners and coroners can be influenced by friends and families of overdose victims and end up classifying deaths as something else, either accidents or as suicides, or sometimes the opposite occurs, not counted as a suicide when it was. So just a little bit of fuzziness around the data. And so these 4 theories might help explain the difference, but it is something we do need to learn more about. And if you are seeking to get involved with harm reduction and methamphetamine overdose prevention in your communities, it is something that is worth looking into, so you can help better understand how to tailor your overdose prevention efforts. And speaking of prevention, At this point, I'm now going to turn things over to Emily to talk a little bit about what prevention can do in general and specifically around use prevention. And I'll be back again in a little bit to talk about overdose prevention. So thanks all again for paying attention and for responding to my questions. And Emily, why don't you take things away?
Great, thanks, Josh. Hi again, everyone. So the next section, I'm going to be talking about ways that prevention can take action regarding methamphetamine use. I've been seeing a lot of chat about this in the chat box, which is great. However, some of you may be disappointed because as we'll talk about, a lot of prevention efforts have really been geared towards youth, but we'll talk about that in just a little bit. So we'll just quickly cover, risk and protective factors and how it relates to likelihood of use. We know that risk factors are the characteristics that are associated with a higher likelihood of a negative outcome, such as substance misuse. We see them at the biological, psychological, familial, community, as well as cultural level. Some of them are static, so they might be fixed over time, while others are more variable, such as income or health. And each factor can increase, the risk, or decrease the protective factors, the likelihood that someone will engage in substance use. And we know that substance use professionals can use several different models to understand these factors and how they all interconnect to each other. There are several risk factors that are known for methamphetamine. Some of them overlap with substance misuse overall, while others are more unique to the substance, and we'll cover those in just a couple slides. We know that methamphetamine use is driven by both specific factors as well as general factors. So in other words, factors that are specific to methamphetamines in particular, and factors associated generally with substance use. Specific factors are the aspects that include things like people's perceptions of harm of methamphetamine use, peer pressure to use methamphetamine, price and availability of the substance, et cetera. An example would be having a positive perception of methamphetamine use, specifically that it can be used to increase your energy, decrease your exhaustion, help with weight loss, et cetera. And that has been found to be a pretty large risk factor for women. Data on specific factors isn't always easily available, but what it is, you can sometimes get a causal link that can then be drawn between the factor and the use. And then on the other hand, we have general factors, which really offer an enormous number of different aspects, ranging from a person's problem-solving skills to their access to quality education. Data on general factors, again, isn't always readily available, but these are often the factors that we want to focus on because it's more common for them to be underlying causes of whatever substance use is occurring. And general factors can include some really big aspects of our lives and environments around us, which is why we're going to talk just a little bit about the social determinants of health, which really are those big picture sort of factors. So the U.S. Department of Health and Human Services defines the social determinants of health as the conditions in the environments where people are born, where we live, learn, work, play, worship, and age that affect a wide range of health, functioning, quality of life, outcomes, and risks. Sometimes trying to address our social determinants of health can be intimidating, but these are really the key influencers of substance use, including methamphetamine. Again, these are really the sort of big picture aspects of our lives. And the social determinants of health have a major impact on people's health, our well-being, quality of life. Some examples of social determinants of health include, safe housing, transportation, safe neighborhoods. They include racism, discrimination, as well as violence. Education, what are your job opportunities? Income, access to nutritious foods, as well as physical activity. Also looking at pollution relating to air and water, language and literacy skills. And we can see that there are 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, which really kind of get to those examples. We know that social determinants of health can contribute to a wide variety of different disparities and inequities. For example, folks who don't necessarily have access to grocery stores with healthy foods are less likely to have good nutrition. This can raise risk levels for heart disease, diabetes, obesity, and can even lower life expectancy. So we know that just promoting healthy choices aren't going to eliminate health disparities as well as other disparities. So this is really where we want to have that collaboration between different organizations across different sectors: education, prevention, transportation, housing, local government, community resources, et cetera, where we can really have that collaborative environment to come together to try and address and tackle a lot of these issues that are very much interconnected. And prevention really has an important role to play in overall public health that focuses on the social determinants of health and really getting that stakeholder involvement. And then when we really understand the social determinants of health, we learn more about the landscape in which we're working in with our interventions and with our prevention programs. So some previously identified risk factors for methamphetamine include genetic predisposition, personal history of opioid, alcohol, or tobacco use, family history of substance use, alcohol use disorder, or criminal behavior, engaging in risky sexual behavior, lower educational attainment, lower annual income, living in a non-metro or small metro community, having a co-occurring mental health disorder, and unemployment. Also, sometimes adverse childhood events in some cases have been shown to be a risk factor, but more research around that one is needed. So based on the data that Josh and I went over earlier, we can really see the connections between methamphetamine use and many of these risk factors. So we want prevention professionals to look at these risk factors, but also think about whether all of these are necessarily still relevant. If methamphetamine use patterns in their communities are different from those in the previous waves, like we've talked about, risk factors may have also changed. So this may also be something that may be changing nationally as well as in your community. So that's just something to keep in mind. So now we'll turn and talk a little bit about methamphetamine prevention efforts. Historical methamphetamine prevention approaches have really included that focus on law enforcement efforts. This includes taking actions such as breaking up labs that produce it, as well as the arrest of individuals producing, selling the drug, et cetera. Additionally, some substance abuse prevention evidence from other areas shows support for the use of different media sources to garner public attention and awareness in the community. So sort of those social media campaigns, sometimes even norm changing campaigns. And that has been shown, that's been more of the focus when looking at methamphetamine prevention historically. However, and, going back to what a lot of people have written in the chat, there just really, unfortunately, is very limited research on prevention programs for methamphetamine in general, and especially for adults who are using methamphetamine. Currently, there's a few different prevention programs that might be implemented to help reduce future rates of methamphetamine use, but many of these resources tend to be geared more toward substance use prevention more generally, not necessarily with that specific focus that we're looking for on methamphetamine. Again, one area that really needs greater focus in terms of prevention is for young adults and adults who use methamphetamine. So you'll see much of what I'm going to cover in the next couple slides is really geared towards youth only, who have historically been the lowest users of methamphetamine. So just something to keep in mind. So one program I do want to highlight that is available is the Substance Abuse and Suicide Prevention Program, which was formerly known as the Methamphetamine and Suicide Prevention Initiative. It was developed for and is currently implemented in American Indian and Alaska Native populations, so much of our indigenous communities. So the SAS program really works to promote culturally appropriate prevention and treatment approaches while utilizing evidence-based and practice-based models to target and address methamphetamine abuse, as well as suicide prevention within an American Indian Alaska Native community-driven context. This program spans 4 different purpose areas. And so the program really works on community and organizational needs assessment, strategic planning, suicide prevention, intervention and postvention, methamphetamine prevention, treatment and aftercare, and then Generation Indigenous Initiative support. So this program was started as part of a pilot in 2009, and then in 2015 was actually extended for 6 years, and that newest grant cycle just closed. So hopefully we should be getting more data information. But this is really one of the few programs that are out there that really target methamphetamine specifically. So in the regions represented here on today's webinar, I was able to find that funding has been allocated to organizations in New Mexico, Minnesota, Oklahoma, Illinois, and Michigan, as well as in many areas of the Great Plains region and other states as well. Just some data about this program and what it has been able to accomplish. Just in that first wave of information from them, we know that between 2009 and 2015, the program had over 12,000 individuals enter treatment for methamphetamine abuse. They had experienced more than 16,560 substance use and mental health disorder telehealth encounters. And then they were actually able to train over 16,000 professionals and community members in suicide crisis response. And you can get more information about the program by following the website there. And some additional prevention programs that had outcomes related to methamphetamine use and have shown some promise in reducing risk for methamphetamine use in youth are the ones that you see here on the screen. So we see the Iowa Strengthening Families Program and the Life Skills Training Program. These were described in two studies that were reported on together that were conducted in the early 2000s that targeted rural youth in the Midwest. So these programs have been shown to be more effective in rural youth. So researchers found that participants in the Iowa Strengthening Families Project, which we now know as the Strengthening Families Program, and the Life Skills Training Program in combination with the Strengthening Family Program for parents and youth were significantly less likely to use methamphetamine after participating in the intervention. Notably, when we talk about these two different programs, that none of these programs actually specifically address methamphetamine, but instead are focused on addressing general risk and protective factors for drug use that are associated with school and families. But like we've talked about before, there are some of those risk factors that are more general for all substance use that also will cover methamphetamine. Sort of this other universal prevention intervention that has shown protective effects on youth substance use for methamphetamine and opioids as well is the Promoting School Community University Partnerships to Enhance Resilience system, also known as PROSPER. This is an evidence-based delivery system designed for early adolescent students. So really kind of grades 6 through maybe 9 or 10. So it works to really prevent risky behaviors in youth while promoting positive youth development. So this is a delivery system, and really it's attempting to foster implementation of evidence-based youth and family interventions, and they're partnering it with ongoing needs assessments, monitoring the implementation quality and partnership, and then doing an evaluation of the intervention at the end. Studies have shown that Prosper youth were significantly less likely than control groups to use methamphetamine as well as other illicit substances, but methamphetamines specifically. And these results are seen several years post follow-up. So again, just one thing to note about these prevention programs that I've covered is that all of these interventions are for youth and they take time. So results may not always necessarily be immediately seen. So we really kind of need that ongoing data collection as well as looking at long-term. Additionally, it's important to remember that most users of methamphetamine really aren't these school-age children. So while some drug prevention programming can be useful, youth-specific approaches may not necessarily have an effect on overall methamphetamine use specifically. So again, this is really an area where, as we've now got the data that is showing that we might be entering really quite a large increase in methamphetamine use nationally and in many states affecting different age populations. This is where some research is definitely going to need to be made in the next couple of years. So one question I have for you all is, and you can answer it in the chat, is, what methamphetamine prevention efforts have you utilized in your community or region? Have they been helpful, if anything at all? I know some of you have talked a little bit about that before, but if you'd like to answer that in the chat, that would be great. And I'll just pause here and let folks answer that question if you'd like. I see some questions in the chat, interventions at the community level, asked by Shelley. Unfortunately, in my research around this, I haven't really seen anything that's specifically geared towards methamphetamine, but there are other community level interventions targeting general substance use. But again, haven't come across that in regards to methamphetamine. And like I've been saying, unfortunately, this is just an area where there just is not a lot of research has been published or done that really kind of target more communities. Okay. Strengthening families. Yep, great. Thank you, Helen, for letting us know. Seeking safety support groups. That's great. Is Meth 360 still being implemented? Have not seen anything about that, but I'm happy to look a little bit deeper into that. So Deanne, if you asked that question, if you'd like to follow up, we'll have our contact information at the end and I can do some more research for you. Great. So thank you all so much for answering that question. And I'll just move on ahead for the sake of time and talk a little bit about methamphetamine treatment. Where much of the still limited research around methamphetamine has been done appears to be more around treatment with the hopes of reducing future use as well as trying to prevent relapse. Psychosocial and behavioral interventions are the current clinical recommendations when treating folks who use methamphetamine. However, additional research again needs to be done to see what approaches are likely to be the most effective at treating the specific subset of substance users. So in the areas of medication-assisted treatment specifically, there is some exciting news. There's currently several different clinical trials that are currently ongoing, and hopefully we should have some results. And they're being done by several different medical centers at the national and state level. One promising area for treatment is using a medication approach. Was a recently published study that found that using a combination of extended release injectable naltrexone and daily oral extended release bupropion over a period of 12 weeks in individuals who had moderate or severe methamphetamine use disorder successfully reduced methamphetamine use and cravings. So that's just an example of one of the current clinical trials that are currently being undergone. Evidence-based treatment services that are current best practices for treating stimulant users who use methamphetamine as well as other stimulants include cognitive behavioral therapy, the matrix model, as well as contingency management, all of which have shown some effectiveness in the treatment of methamphetamine users specifically. The matrix model is an intensive 16-week approach that combines a variety of activities such as counseling, drug testing, family education to treat individuals. And then contingency management uses a reward approach by providing incentives such as money, gift cards, et cetera, for continued engagement in treatment, clean drug tests, as well as abstinence. So several studies have found that using a combination of these approaches may be more effective. However, long-term follow-up data on relapse has not shown that there's an effective treatment for methamphetamine users. So another area where we really want to increase that research. Other areas where prevention treatment might be useful include, training and preparing treatment providers and other first responders who primarily address the opioid epidemic to provide services for polysubstance use, as the data shows that many meth users also are using other substances. Additionally, the lessons that we've learned from the opioid epidemic might be able to be adapted and implemented for methamphetamines. We know that, there's really no single cause that leads to methamphetamine use. So the utilization of a variety of different evidence programs, strategies, and tools is likely going to be our most effective way to prevent and reduce use, and as well as those associated harms, that Josh talked about. And really, we want to also ensure that there's a lot of that collaboration across multiple agencies, like we talked about with the social determinants of health, because we really want to ensure that strong policies are put in place and the people that are most affected by methamphetamine use are being reached. So at this point, I'm going to hand the presentation back over to Josh. Oh, I do have one more question, actually, asking, do we have any folks here who also work in methamphetamine treatment? And if so, have you utilized any treatment interventions? So I'll just pause here for a second and see. Okay, so at this point, I will hand the presentation back over to Josh. And I really appreciate everybody's support and all the information that you're posting in the chat. And I will take a look now and try and address any questions that you might have. So Josh?
Thanks, Emily. Hi again, everyone. So our final learning objective for today is going to hopefully be a little bit more of an optimistic note to end on when we talk about recommendations. But before we get to that, just a couple more slides that might be a little frustrating when we talk about current evidence around methamphetamine overdose prevention. So beginning with just talk a little bit more about overdoses in general, just information about them. As I mentioned before, methamphetamine overdoses are complex events. Use has multiple interactions with both the central and peripheral nervous systems, any one of which can lead to toxicity. And so methamphetamine overdoses can lead to heart attack, stroke, or other fatal conditions, which can be difficult to treat. Whereas with opioid overdoses, the vast majority of them are respiratory depression. And so with methamphetamine overdoses, a lot of times advanced medical care is needed to treat an overdose. Generally, some combination of benzodiazepines, antipsychotics, antihistamines, and beta blockers are used, depending on what the specific symptoms of the overdose are. And in addition to that, with opioid overdoses, there's a reversal medication, naloxone or Narcan. There is no overdose reversal medication for methamphetamines, at least not as of yet. So as the next slide shows, there are a lot of barriers we face as we try to implement methamphetamine overdose prevention campaigns. First of all, as I mentioned, no overdose reversal medication. Also, the symptoms of an overdose, because they can be so varied, it can be hard to identify when specifically an overdose is occurring, and also distinguish when it's happening versus when just you're seeing the normal effects of use, which means it can be hard to do sort of a training campaign around people, giving people, well, here's how you know that a methamphetamine overdose is happening, and you should contact 911. There's also the added barrier that someone experiencing a methamphetamine overdose may experience a risk of self-harm or harm to others because of psychosis or other methamphetamine-induced mental health conditions. And also, with opioid overdoses, there's been a lot of, pretty much every state has changed their laws to some extent to help address opioid overdoses, but in a lot of cases, those laws were specific just to opioids. So for instance, many states passed Good Samaritan laws where, if you reported an opioid overdose and police were part of the first responders that came to it, the laws stated, although the police didn't always follow this, the law stated that you wouldn't get arrested for possession because you were covered by the Good Samaritan law, for opioid possession. Most states, that doesn't apply to methamphetamines. So someone, we're calling in about a methamphetamine overdose, if they possess methamphetamines, might think and might be at much higher risk than getting arrested for possession. And so because of all of this, there's currently a lack of evidence-based strategies to support laypersons in addressing methamphetamine overdoses. We can't just implement the equivalent of an opioid overdose and naloxone distribution program, because we don't know yet what best practices are around education, and we don't have the equivalent of naloxone. So there's barriers. And there's also barriers around just use prevention, as Emily talked about. Now, as I said, we're going to end things on a bit more of a positive note, talking about recommendations for overcoming these barriers. But before I give you sort of my thoughts on this, I want to get your thoughts on this, on how can we work to be overcoming all these different prevention barriers. And so just get your thoughts on that. I will pause for just a moment because I do want to make sure we can give those recommendations enough time before we have to close things up today and get you out of here. So. All right, so if you do have thoughts on it, please feel free to type. The Zoom chat doesn't let me know if folks are typing currently, but in the interest of time, I'm going to move on to sort of our recommendations for how we can move forward, beginning with adaptation. And so the fact of the matter is, although there is a lot that we don't know yet about how to deal with this current wave of methamphetamine use and overdoses, we do know some things that we can do because we've gotten a lot of lessons learned and best practices that we've obtained through the the crucible of the opioid epidemic. Now, not all of these best practices are going to be directly applicable to dealing with methamphetamines, but a lot of them are. So for instance, we should be continuing to use strategic planning to, identify our key needs and collect data and identify the gaps in services and ways to address them. That way, when more evidence-based programs are identified, we're already in a position where we can just start implementing them, and we're not, starting from zero. We should also be continuing to build out our prevention infrastructure. We know that we're going to be wanting to work with a lot of different partners in the communities around these issues, and possibly, implementing promising programs with them, various media campaigns and messaging events, and then, getting ready for, well, if something more specifically evidence-based is identified, begin to implement that as well. We can also, when new programs do become identified, model them around existing ones. So for instance, if we do start learning about, effective ways to give people education on how to identify a methamphetamine overdose, we could be, modeling how to get that information out into the community the same way we've done opioid overdose education. And we can also advocate for expanding opioid specific policies and laws to include methamphetamine as well. For instance, I mentioned the Good Samaritan laws. We could be advocating for those to be expanded to include methamphetamines as well. Another recommendation is education, which is, there's a lot of people out there that we need to make sure they understand the need to address methamphetamine use now before it becomes a larger epidemic. And there are specific actions that a lot of different stakeholders could be doing, but we need to get them to understand why they need to do it. If you look at the opioid epidemic, for instance, it was actually pretty clear in the data by 1999 that there was a problem going on. It wasn't to the extent the data is now, but it was clear there was a problem. It wasn't until 2011 that the CDC officially declared there'd be an epidemic in place, and it wasn't until 2016 that there started to be a massive influx in federal funding to deal with the epidemic. So, 17 years after the problem was severe. And obviously there's prevention work going on before then, but there was a big delay. We don't want that same kind of delay happening. We need to be educating people now, in the equivalent of 2002, 2003 for the opioid epidemic, and getting them to understand that this is an issue we need to be working on, educating policymakers on the need to approve additional funding, educating prevention researchers on the need to test new interventions, and, be figuring out what kinds of strategies we can do that will work out, as well as making sure that our fellow prevention practitioners understand the need to share their data if they're collecting it. If some other county or city is testing some new messaging campaign or some new other prevention programming, we really want to make sure that they understand the need to share their data, and so we can more quickly learn about what is effective and what isn't effective, and also be educating communities on the need to be ready to act, to understand that this is an issue we need to be getting ready to address, and talking with fellow members, community members about. Another recommendation is to make sure that we are implementing the things that we can be implementing. Implement the interventions that are showing evidence of effectiveness. As Emily talked about, there aren't too many right now that specifically show evidence of effectiveness, but those ones that do, if they're appropriate for our communities, we should be implementing them. And if they're not, we should still be implementing whatever promising programs we can find, or even testing out new things, just trying things out, because that's how the evidence base gets built. Of course, we need to have funding that allows us to test things, but we do want to do that to the extent we can. And that means, possibly working with researchers to pilot new programs, and trying to develop new campaigns and if we have campaigns off the shelf, even if they haven't been fully tested yet, sharing them, making them public and saying, here's campaign materials, you can try them out as well. We can also be working with law enforcement to support their interdiction efforts, because when it comes to supply reduction, we do know that obviously that doesn't solve the problem, but it does at least help reduce access and availability. And so trying to work with them on that. And then finally, we should be taking advantage of funding flexibility when it exists. So because all the other recommendations I mentioned do take money. So if you don't know this, there's a lot of opioid-specific prevention funding over the past few years coming out from the federal government that these days now includes language about, well, stimulants in general, not just methamphetamines. And it's often a disclaimer around, if you can provide data about local need, that there's a local need for stimulant prevention or stimulant treatment, you can use this funding for that rather than just opioid funding. So for instance, a lot of the SOAR, the State Opioid Response Grant funding has had that kind of flexibility. So we should be looking out for that and even if we're not that concerned about opioids, or we are concerned, but we already have a lot of funding to deal with opioids, still be looking at those grant announcements when they come out and see if they actually do have in their RFP language around, we can actually use this for stimulant problems as well, and try to get additional funding. And we can also be advocating for other funders to add that kind of language if there is the need for it. And based off the poll earlier at the start of this webinar, it seemed like a lot of you think that this is an issue in your community. So making sure we have the data on that and sharing that data to get people to understand why this flexibility is needed. So in conclusion, methamphetamine use and its consequences are rising. We went through all that data. You do want to get additional data, obviously, for what specifically is happening in your local communities, but this is a starting point. And we do need to be prepared for the likelihood that use and its consequence has been exacerbated by the COVID-19 pandemic. The current wave of use appears to be more widespread than past waves, both in terms of sort of covering more age ranges, but also it is appearing in other areas as well. That's not a thing we talked about so much today because we were specifically talking about the two regions, Great Lakes and Southwest. But if you look at other regions of the country, like the Northeast, methamphetamine use rates are low there, but they are a problem for pretty much the first time ever. It's becoming much more of a national issue rather than more of a localized one. And so because of the data that we've talked about, we do need to be responding as quickly as we can to bend the curve, which I think is a phrase we all got pretty familiar with in the concept of COVID last year, to try to prevent these trends from increasing as much as they otherwise might. There are some steps that prevention can take now, which we talked a little bit about, including just raising awareness of the urgency of the problem and getting more people on board with the need to be dealing with this issue, and trying to obtain additional funding. And I see some folks have been sharing in the chat that they've gotten SOAR funding or SOAR 2 funding to include stimulants. And yeah, that is sort of one big area where we can get funding on that. So that was a lot of content today. I want to thank you all again for joining us. At this point, I believe we're going to pause to give you all a chance to ask any additional questions or re-ask any questions that we might have missed. And if you don't have any questions, don't go away yet, because after the Q&A is over, I'm pretty sure that there's an evaluation, speaking of data collection, that we're going to want you all to complete. So yeah, let's just pause for a moment to see about questions. And I see Richard's also shared that evaluation link in the chat already, although I believe we're going to tell you a bit about it in a couple minutes as well. So yeah, I'm going to stop talking for a minute to give you all a chance to ask any questions. I also, since I haven't any questions popped up yet, also I note that if you think of any questions in the future, please feel free to reach out to Emily or me directly, or reach out through your PTTC, and I'm sure they have lots of information they can give you as well, or maybe they'll reach out to us about it, but we're happy to answer any questions in the future. I haven't seen any questions pop up yet.
There's a question, Josh. Do you have any recommendations for trying to measure use in a hard to reach rural Native population?
Yeah, well, that is a good question. And yeah, that is a hard one to do, hard to do for sure. So as part of the National PTTC Data-Informed Decision Work Group, I recently was working on a tool around data collection well, it started off as in general when we talk about surveys, focus groups, and key informed interviews, but and it wasn't specific to indigenous populations, but we had someone in that work group from the Native American Alaska Native PTTC Center, and because of her feedback, we included in that products, which I'll try to find a link to share in the chat, sort of information around culturally specific data collection, so things around visual expression. I know a lot of rural community, indigenous communities sometimes use things like photo voice, for instance, as well as sort of more even more culturally specific ones. Also things like talking circles around trying to collect data and storytelling. But the first step is going to be probably trying to reach out to the community leaders or elders and sort of working with them to figure out how to collect that data, because it's probably not going to work without them. So yeah, reach out to them first, and then I will also try to find that link to share with you in the chat, which also had links to additional resources that might have further information that could be helpful for you.
Great, Josh. The next question is, I'm curious if prevention/academics detailing around prescription stimulants has an impact on illicit methamphetamine use.
So that is a good question, and it's hard to know for sure that something could be happening in one way. Well, let me back up. Data shows that prescription stimulant misuse is higher than methamphetamine use, which we would expect because it is, more readily available. It has, though, actually been going down over the past few years. So there could be a bit of a substitution effect going on, which is something we saw with opioids, where when prescription opioid misuse started going down, we ended up seeing heroin going up. On the other hand, prescription stimulant misuse is more specifically found among younger adults. The risk factors are a bit different. It is much more around people in college and high school, and that sort of risk factor around trying to get extra energy for studying, for instance. Obviously, that's not the only risk factor. That actually is a really big one for prescription stimulants. So it might just be an unrelated, additional area. It is something that we do need to, though, learn more about. And if that substitution effect is going on, we would want to get a handle on that quickly. We don't want to repeat what happened with opioids.
So Josh, there are also lots of people saying great presentation and appreciative of the work that you all have done. I certainly want to remind you all that next week you'll receive these materials. You already have had an opportunity to get access to the brief. Richard, if you could add the brief to the chat just one more time for those folks who got in a little bit later and didn't get an opportunity to look at the methamphetamine brief. Also, you all, since this is a Southwest, as well as Great Lakes PTTC initiative, we will be sharing on our individual websites meth briefs that are tailored to each of our own regions. So you'll make sure to check in with the pttc.org website to get a chance to look at the region-specific briefs that are out there. There was another comment, Josh, and it says, and Emily as well, it says, thank you. We're working with local police department who is starting to do surveillance of paraphernalia in hotspots for use in the community. Do you have anything to add to that, Josh?
Not too much. I mean, I think that's great that you are working with them. Surveillance, epidemiological surveillance is key to identifying the hotspots. And I know there is. It's not something I know as much about, but I know there are resources out there around things like I think it's geographic information surveys, GIS, to try to work in putting together mapping to really identify those hotspots. I know that there's also been talk around trying to use things like social media, like APIs, Google search trends to try to identify hotspots as well. But I haven't seen so much people talk about how they were successful at that, just they were trying to do it. I also want to sort of separately note, I did share a link in the chat, that thing about that resource I mentioned. Page 2 of it is all about those data collection methods for trying to work with indigenous populations. Just as a note there. And that is also found on